Hello, my name is Deb Smith. I'm an Improvement Consultant at Health Quality Innovators, or HQI. This educational event has been developed in partnership with HQI, the Virginia Department of Health, and the Virginia Hospital and Healthcare Association. I'd like you to take a minute to review the icons at the bottom of your screen. There are two green icons to the right. One is for the resources for this education, and the other is the post-test that you will be taking after completing the education. You'll have two chances to achieve a 70% or higher in order to receive your certificate. I would now like to introduce your instructor for today. Rebecca Collins serves as the Interim Clinical Manager, Residency Director, and Education Coordinator for Bon Secours Virginia Health System. She also practices as Antimicrobial Stewardship Team Lead at Memorial Regional Medical Center and Bon Secours Health System. She currently teaches pharmacy residents and students in the clinical area of infectious diseases and offers advanced practice professional experiences in acute geriatric care and internal medicine. She is also a co-founder of the Stewardship Interest Group of Virginia. Rebecca, the floor is yours.
Thank you, Deb. Date back to Sir Alexander Fleming when he stated in the New York Times that the microbes are educated to resist penicillin and a host of penicillin-fast organisms is bred out. In such cases, the thoughtless person playing with penicillin is morally responsible for the death of a man who finally succumbs to infection with a penicillin-resistant organism. I hope this evil can be averted. So basically, we've gone from infectious disease killing people to people being saved by penicillin and antibiotics, now back full circle to these multi-drug resistant organisms killing people once again. If we fast forward to 2000, this concept by saying the healthcare system needs to improve how it detects patients with drug-resistant infections, controls the spread of such infections, prevents them from happening in the first place, and incentivizes drug makers to develop new antimicrobials. So some background statistics I'd like to review include that 2 million Americans develop resistant infections every year. This leads to 23,000 Americans dying from drug-resistant infections annually. Antimicrobial agents continue to be the largest portion of pharmacy expenditures, with up to 50% of antimicrobial use being deemed inappropriate. This inappropriate use can lead to resistance and other adverse events, and appropriate use may actually improve patient outcomes and reduce healthcare costs. Not only see the number of infections and diseases and deaths rising, we also see our sequelae from overuse of antimicrobials rising. For instance, C. diff infections have increased to 250,000 illnesses annually, with approximately 14,000 deaths due to C. diff. There are many other untoward effects of antibiotics that we need to consider. These include the increased antibiotic resistance associated with overuse of antibiotics, increased healthcare costs with up to $30 billion spent annually, and the increased risk of adverse drug events with things such as hypersensitivity, diarrhea, and as we spoke just a moment ago about Clostridium difficile. This is the class of medications that when you use it in one patient, the effects can reach those around them. For antimicrobial resistance, we see an increase in overuse and misuse of antimicrobials, and this forces the bacteria to either adapt or die, leading to selective pressure. Bacteria that can adapt and survive antimicrobial therapy then carry genes for resistance, and these genes are transmitted to future generations of bacteria. If we further look into resistance, we see that bacteria may also colonize and infect organisms, especially as they're becoming more and more exposed to antibiotics. Resistant organisms can be transmitted between patients, and there's some examples here of some of our more common resistant organisms, including methicillin-resistant Staph aureus and carbapenem-resistant organisms. The highest risk patient groups that acquire resistant pathogens include those that are immunocompromised, our hospitalized patients, and those that have invasive devices placed, such as central venous catheters or Foley catheters. Some further indirect impact to the patient includes increased office visits, lost time from work, severity of illness, increased length of stay if they're hospitalized, and patients having adverse events from multiple antibiotics. This can even lead to death. So why do we need to worry about antimicrobial stewardship? We definitely need to improve our antimicrobial prescribing. We also need to minimize misdiagnosis and delayed diagnosis and the underuse of antimicrobials when needed. We also need to ensure that we're using the right drug, dose, and duration of therapy, and we can track these things over time to make sure that we are prescribing in an appropriate manner. We can also use this tracking to help us show a slowing in prevention of development of resistance. The Center for Disease Control has developed some guidelines for a core group of team members that can be part of your antimicrobial stewardship program. Here's a list that is inclusive but not limited to infectious disease providers, clinical pharmacists with infectious disease training, clinical microbiologists, information system specialists, infection control professionals, and hospital epidemiologists. And of course, you definitely require the collaboration and support of your hospital administration, your medical staff, and any local providers and pharmacists involved in the care of the patient. Some benefits of antimicrobial stewardship include the improved clinical outcome, providing more cost-effective care to our patients by decreasing the use of costly antimicrobials and also decreasing the length of stay, especially when they're hospitalized, reducing readmissions to the hospital setting, and preventing hospital and healthcare-associated infections. We also can decrease adverse event rates using antimicrobial stewardship. Some further benefits include curtailing antimicrobial resistance, such as our multi-drug resistant organisms that we mentioned earlier, also reducing overall healthcare expenditures, and both of these regulatory bodies here require that we do this, and we need to make sure that we're meeting those requirements from the Joint Commission and the Centers for Medicare and Medicaid Services. Some strategies used are core strategies, which include prospective audit with intervention and feedback. This is basically your prospective review of a patient on a daily basis to make sure they're receiving the most appropriate therapy. You also can use formulary restriction and pre-authorization. This would restrict those agents that you would only want to use in a setting of resistance or intolerance for the patient. And then supplemental strategies include education, guideline and pathways to help direct therapy, streamlining and de-escalation of therapy, dose optimization, IV to PO conversions, and computer-assisted decision support for different infection types. Antibiotic use definitely can lead to resistance, as we've mentioned earlier. So we definitely want to look at patients with a history of antimicrobial use and monitor their risk for resistance. We also want to look at antibiograms and determine if regions have a prevalence of antimicrobial resistance. We can definitely change our prescribing patterns to help to curtail resistance or to also lead to resistance, so we need to be monitoring that with some of our metrics. And then we want to look at dose-response relationships and making sure that we're optimizing the dose for the antimicrobial and for the patient. So what can we do as pharmacists to help improve this scenario? There's several things that we have listed here. We definitely can review culture data and de-escalate therapy when appropriate. We can help optimize our dosing strategies, both based on the drug and also the pharmacodynamic effect of the antimicrobial in the patient's body. We can also do medication use evaluations and look for trends in prescribing that may be leading to resistance. We can look for drug allergy information, and we can also promote our antibiogram to make sure they're readily available when prescribing is occurring, and definitely helping the patient to know what the adverse drug events are and to help with monitoring of those. So for example, in an antibiotic allergy history, most people who believe that they are allergic to an antibiotic can take that antibiotic without a problem, and they may not even have a true allergy. So it's a good patient antibiotic history can help sort out whether or not these patients can actually receive that antibiotic in question. So here we have a list of questions that you can ask your patients. This would include, does the patient remember having an allergy, or was it just told to them by a parent or grandparent? How many years ago was the reaction? Was the reaction with the first dose? How was it treated? What occurred when the action happened? And did the patient take other medications at the same time that could have led to that reaction? If the patient is unsure of these questions, you may be able to try that antimicrobial and actually use it to treat an infection for the patient. Other strategies to improve antimicrobial use include making sure that the patients are adherent to their therapy, also making sure that the providers are adherent to practice guidelines. We have a lot of clinical pathways that we can use that are based on guidelines and evidence that help us streamline our therapy for our patients once a culture is returned, using appropriate dose and duration only when the antimicrobial is necessary, and looking for things like adverse events, symptom management, and helping with antimicrobial resistance when we're talking with providers. An example of prevention strategy that we can use as pharmacists is in the management of upper respiratory tract infections. These infections occur primarily in the outpatient setting, but we do see them in both the inpatient and outpatient environments, and they're associated with about 15 million infections per year, and they account for about 68% of all outpatient antibiotics. However, the majority are caused by viruses which would not need any antibiotic therapy. In fact, for pharyngitis, only about 15 to 30% are actually caused by bacteria, and sinusitis, about 80% has a viral cause, and for otitis media, 80% can resolve spontaneously without any treatment. So most cases can be treated by a watch and wait approach with symptomatic management. So let's look specifically at some of these upper respiratory tract infections, the first of which is acute otitis media, or the common ear infection. As we see with treatment guidelines, the lowest risk children, those that are greater than 2 years of age, have had no recent antibiotics and have no history of an ear infection, can actually be observed for 24 to 72 hours before antibiotic therapy is started, if it's needed at all. Whereas those with the highest risk, you would want to go ahead and treat them with antimicrobial therapy. So what does that watch and wait look like? If we look at the number needed to treat to prevent 1 case of ear pain, it takes about 20 children to be treated with antimicrobial therapy just to prevent 1 case of ear pain, and 33 children needed to be treated to prevent 1 perforation, whereas 1 in every 14 children will develop diarrhea, rash, or vomiting from antimicrobial therapy. So as you can see, it's much more risky to treat them with the antimicrobial therapy if they don't need it due to the adverse events associated with that therapy. So a wait of 1 to 3 days before initiating antimicrobial therapy may be warranted in acute otitis media. If we look at another upper respiratory tract infection, pharyngitis has treatment guidelines that recommend that most of the time in children less than 3 years of age, this is going to be a viral infection, so it's rarely going to need antimicrobial therapy. And then you can use other strategies to determine the risk associated with an actual bacteria pathogen, group A strep, in the diagnosis of pharyngitis. So the peak incidence of this group A strep is between 5 and 15 years of age. You definitely want to look at other non-infectious causes such as allergies, malignancy, chemotherapy or chemical exposure, and direct trauma to the area such as drinking something hot. that could be causing the throat pain before you automatically jump to a antimicrobial therapy. There are some criteria for the rapid strep test. First of all, you definitely want to determine when to treat versus who are at the lowest risk of having a strep bacterial infection. So you definitely would use that primary age group of 4 to 15. And some of the Centaur criteria that can be used to determine whether or not they need antimicrobial therapy are a fever greater than 101, a tonsillar exudate or pus at the back of the throat, absence of a cough, or cervical lymph node involvement. If they have 2 or more of these, you probably do want to go ahead and test them for strep and rule out other causes if necessary. And then finally, the third respiratory tract infection that we wanted to discuss is sinusitis. Treatment should only be offered to patients who have an onset of symptoms that are lasting for greater than 10 days without improvement, have an onset of severe symptoms, or have a very high fever with a very purulent nasal discharge or facial pain, or have worsening of symptoms. And sometimes this is deemed the double sickening, where they actually had a viral infection primarily that lasted 5 to 6 days, and that trapped bacteria causing a bacterial infection, which led to the need for antimicrobial therapy. So definitely using those criteria to determine whether or not a patient needs therapy. Some other prevention strategies and using vaccines for vaccine-preventable infections. Some of these are listed here below. The most common, obviously, are influenza and pneumococcal infection, but we also definitely want to vaccinate our children for some of these others. And then there's also travel vaccines that we can use to prevent things such as malaria when we travel to other countries. Another common part of the pharmacist is to provide patient counseling. We definitely want to encourage the patient to finish their full course of antimicrobials. Also tell them what to look out for when they're taking their antimicrobials, whether it be the most common adverse effects like rash and diarrhea, or something less common that they may run across when they're taking therapy. Also emphasize adherence, making sure if they've taking something several times a day that they take every dose. Looking at other ways to manage their symptoms, helping them with antipyretics and analgesics. Also providing them with tools to measure whatever symptom management agent they're using. Especially in children, it's really important to provide them with an exact measuring device versus a tablespoon. Also talking about alarm symptoms. So if you're using that watchful wait approach where you're actually watching a child for 48 to 72 hours, you want to give them parameters by which to seek help if they start to have worsening of symptoms. Some other responsibilities of the pharmacist includes discharge planning if they're in the hospital, also providing education to other healthcare providers, performing formulary reviews of new or reformulated antimicrobials. It's really important to get ahead of the prescribing pattern before it starts. So when you have a new agent, to review it and make sure that you have criteria developed for use of that agent. Precepting and mentoring pharmacy students and helping them understand the principles of antimicrobial stewardship, providing presentations at local, state, and national levels, and then conducting research to help to control antimicrobial use, maybe restrict use, and also aid in reporting of good antimicrobial stewardship practices. And then one further role, looking at colonization versus infection. Infection suggests that the invasive microorganism, like a bacteria or a fungi, is actually penetrating the tissues of the body, and so that results in signs and symptoms such as fever, pus, high white blood cell count, pain, or organ dysfunction, whereas colonization is just the microorganism, whether it be a bacteria or a fungi, that actually resides in the body without invading the tissue. So it doesn't cause those signs and symptoms that we just talked about. So there's a lot of different microorganisms that can colonize the skin, the wounds, airways, GI tract, urinary tract, or the mouth or the nose. So it's really important as pharmacists for us to be able to distinguish between infection and colonization so that we can help make good treatment choices and determine when antibiotics are needed. An example of this is asymptomatic bacteria. A bacterial urinary tract colonization should not be treated with antibiotics. That means unless a patient has a symptom of a UTI, bacteria in the urine should not be treated. And so we definitely don't want to treat a UTI based on urine smell or appearance, and we're in a great position to reinforce these principles with patients and their families. And then 4 strategies that we've discussed earlier, but just wanted to highlight again. We definitely want to make sure that we don't take any antimicrobials for viral infections, that we're obtaining cultures before we're starting antibiotics, and that we don't treat those colonizations that we just talked about. We want to discontinue therapy if it's a non-infectious diagnosis. So a good example here in the hospital is looking at pneumonia versus heart failure. If you have an unclear chest x-ray and then a CT is performed and it definitely shows a fusion versus a bacterial source or a pneumonia source, then you definitely can streamline and discontinue antibiotic therapy. And then limiting the duration of therapy to the appropriate length based on evidence with common infection types. And this is something that we're definitely trying to do more in both the outpatient and inpatient settings. And finally, just to review the Clostridium difficile infection risk factors, we definitely want to decrease the use of antibiotics that are frequently associated with this infection type. And some of the more common ones are things like broad-spectrum penicillins, an example being Zosyn, or broad-spectrum cephalosporins such as ceftriaxone. These agents definitely frequently lead to CDI, and so we want to make sure that we're limiting the use and only using them when absolutely necessary. And although all antibiotics can cause C. diff, these are the ones that we want to focus on especially. And so just to mention, by making antimicrobial stewardship part of your daily practice, you can improve patient safety and care, reduce the unnecessary use of valuable resources, and reduce bacterial resistance. Thank you.
Thank you, Dr. Collins. I'd like everyone to please take time to look at these resources on this page. You can use these in your practice. Now that you have completed the review of the resources and you listened to this recorded education, you're ready to complete the post-test. Click on the green icon to the right, the one with the pencil, and complete your test. Once you've passed the post-test with a 70% or higher score, you will receive a certificate for credits in the email within a week. We appreciate that you have used this education and hope that it will help you in your practice.